everyone, welcome to SureenaSpeaks, and in this BNF bite-sized style video, I will be covering migraines, types of migraines and treatment options. And I hope you find this video useful, and if you do, don't forget to hit that like button, share and subscribe. So as someone who has previously had migraines, I can tell you they are no joke. Migraines can last between 4 to 72 hours, and they are characterised by recurrent attacks, which can be classed as moderate or severe. The headache is typically on one side of the head, so unilateral, and can affect daily routine. It can be really debilitating. Migraine can be subdivided into migraine with aura and migraine without aura, and it can be defined as chronic or episodic. So episodic is defined as suffering less than 15 days per month from a headache, whilst chronic is defined as suffering from at least 15 days per month from a headache, of which at least 8 of those days have the characteristics of a migraine for 3 months or more. I experience migraines with aura. That means that I usually get visual symptoms before my migraine comes into full effect. So usually I get floaters or even partial sight loss, which is common in someone who suffers from migraines with aura and is kind of the warning symptom that a migraine is going to happen. Other general visual symptoms include flickering lights, zigzags, and some people also experience sensory symptoms such as pins and needles or numbness, as well as speech or language symptoms such as dysphasia, not to be confused with dysphagia. If an individual experiences any of these, plus at least 3 of the symptoms that I will list over here nicely for you, and there is no other reason or diagnosis to account for the headaches, then migraine with aura can be diagnosed. So how can migraine without aura be diagnosed? Well, if a person has at least 5 attacks and meets a certain criteria, it can be diagnosed. That criteria includes a headache lasting 4 to 72 hours in adults, and the headache presents with at least 2 of the following. So a unilateral location, and a throbbing, pulsating quality, pain is moderate or severe, and it affects daily routine. As well as that, the headache must be associated with nausea and or vomiting, photophobia and phonophobia, and there is no other diagnosis to explain the reason why the individual is experiencing this type of headache. Symptoms start slowly and usually resolve within an hour, but it is a painful hour. For me, like many people who suffer with migraines with aura, I become really sensitive to light, so photophobia, and all I want to do is cover myself with a duvet in a room that has the curtains closed to get it as dark as possible. That's the only way that I can get some kind of comfort and relief. And I get quite nauseous and I do tend to vomit, after which actually I feel a bit better. The exact cause of migraines is unknown, but many possible migraine triggers have been suggested. Some women experience migraines around the time of their period. Just before menstruation, estrogen levels drop, and it's thought that this could be a trigger. Symptoms can occur 2 days before the start of bleeding to 3 days after. There has been suggestion of emotional triggers such as stress, anxiety, tension, shock, or even physical triggers such as tiredness, poor posture, neck or shoulder tension, jet lag. Suggested dietary triggers include dehydration, missing meals, alcohol, caffeine products, chocolates, or food containing tyramine, so cured meats, yeast extracts, smoked fish, for example. Environmental triggers include flickering lights or flickering screens, bright lights, loud noises, strong smells. I myself haven't figured out what my trigger is, and I genuinely don't know why I get migraines. It just seems to be quite random. But after my last few migraines, I've started keeping a diary of what I ate the day before my migraine, what I ate on the day of my migraine, how I was feeling, what mood I was in, to see if there are any correlations. And I would recommend the same for anyone who suffers from migraines and who isn't quite sure what is triggering those migraines. Medication overuse headache is a complication of migraine. Taking treatment for migraine on an acute basis frequently can actually increase the intensity and frequency of headaches. Now, before we go any further, if you are looking for questions on every chapter in the BNF, plus over-the-counter type scenario questions, then do make sure to check out Clinical Quizzical, a question bank which tells you instantly if you've got a question right or wrong, and that gives you the flexibility to answer questions on any particular topic. Link is in the description box below, and I'll also include a link to a demonstration video too, so go and check that out. Let's now focus on treatment options. So choice of treatment depends on the severity and frequency of the headache attacks, if there are any comorbidities, patient preference, and previous response to treatment. So first-line treatment options include aspirin, ibuprofen, or a 5-HT1 receptor agonist termed as triptans. A friend of mine knows that if she takes ibuprofen, as soon as she starts to experience aura symptoms, she can actually significantly decrease the amount of pain and debilitating nature of the migraine. However, for those taking triptans, it's actually recommended that an individual takes the triptan at the start of the pain of the headache rather than at the start of the aura, unless of course the individual experiences both the aura and the headache at the same time. An example of an over-the-counter triptan is sumatriptan. It's really important that patients are counseled properly on how to take it. So it's recommended that for sumatriptan 50 milligrams, one tablet should be taken for one dose, and then a following tablet can be taken at least 2 hours after if required, but it should only be taken if the migraine recurs. If a patient has taken the first dose and they haven't really responded to it, they should not take a second dose for the same attack, and that is a really key counselling point. So a dose of sumatriptan 100 milligrams may be required, but that should only be taken under the advice from a prescriber. For over-the-counter, one 50 milligram tablet, as explained, is what is advised. And there are other examples of triptans. These include olmatriptan, naratriptan, rizatriptan, zolmatriptan, and if a patient doesn't respond to a particular triptan, then an alternative triptan can be tried. If a patient experiences early vomiting or has severe migraines, then subcutaneous sumatriptan or nasal zolmatriptan can be given. In patients who fail to respond to monotherapy, then combination therapy with sumatriptan and naproxen can be tried. Antiemetics may also be required for those who experience nausea or vomiting when they have migraines. So examples of antiemetics include metoclopramide or prochlorperazine. But due to the risk of extrapyramidal side effects, metoclopramide is not recommended for regular use. So that was treatment, but there may be instances where preventative migraine treatment may be appropriate. This is particularly in cases where the migraine is affecting a patient's quality of life. First-line preventative treatment is propranolol. If this is unsuitable, then another beta blocker might be considered, such as metoprolol or nadolol. If you want a quirky video on remembering beta blockers and their different indications, then make sure to check out my beta blocker wrap video. Yes, you heard me correctly. If a patient can't take propranolol, then topiramate is also an option. However, in women of childbearing potential, advice should be provided on the potential associated risks of taking topiramate during pregnancy and the need for highly effective contraception. Amitriptyline is also another option licensed for migraine prophylaxis. If 3 or more oral prophylactic treatments have been tried and failed, and an individual suffers from chronic migraines where medication overuse headaches has been addressed, then botulinum toxin type A may be suitable, but this would be under specialist use only. So I hope you liked this video, and I hope that it helps with your understanding on the different types of migraines, general symptoms and treatment options. Don't forget to visit my Facebook, Instagram and Twitter, and do show your love for this video because I do greatly appreciate it. Until next time, good luck with your revision and happy revisings!